Anybody have any questions on the time frames that you can have some of these? Again, you know, clot retrieval, 8 hours, and there's many different types of clot retrieval, so they do go up to 12 hours to remove them. So here's just some occlusions, some of his, go ahead, here's a carotid. You can see the blockages here, different areas. Now, when you go ahead and you bring a stroke patient to our hospital, we're going to go ahead and we're going to stabilize them. We actually currently are partnered, I believe, with Rush Hospital, who is a comprehensive. We're waiting for Resurrection to go ahead and finish theirs, but we're going to get that CT scan. If the patient is eligible, we're going to go ahead and get TPA going. We've partnered with Superior Ambulance, that when you guys call in a stroke alert, our nurses will go ahead and page the stroke team from Superior to go ahead and respond to the hospital, because the sooner we can get them transferred to that comprehensive hospital, the better the patient's actually going to fare. So they'll send them when TPA is running. They're going to do multiple neuro checks and vital signs during their transports. Something else that, you know, I told you earlier that American Heart is really doing a big public awareness, big push for the general public to recognize the strokes. If you guys are having open houses or, you know, things that you put out, tables for the general public, you can contact the Stroke Awareness at American Heart. They will send you a lot of free materials that you can go ahead and put out on the table for your citizens to be able to help identify stroke. So it's, and it also gets some of your public education out of the way for stroke centers. So it's a good website, and it's all free. They send it out as much as you need. We taught a lot of, you're going to start to hear a lot of big push on getting family cell phone numbers or phone numbers and putting them in your PCR. It's not a push right now. It's a big talk. I don't see right now the real benefit. Most of the time family members are there. If it's a person having a stroke, the likelihood you're going to get a cell phone number from them is pretty slim. So it'll probably be coming down the pike that that's one of the other pieces of information that you're going to get. But for the time being, just go with what you've always been doing. Does anybody have any questions on managing stroke patients? Pretty easy to manage, pretty straightforward. And like I said, these are really one of the patients that we're going to load and go with. Get them to the hospital as soon as we can. All right, we have two medications that we're going to go over. The first one is Lasix. What is Lasix? Diuretic. Anybody remember where it works? Specific area? Loop of Henle? Yeah. Something about some of these diuretics. There's various diuretics. There's potassium-sparing diuretics. There's non-potassium-sparing diuretics. One of the things we have to really watch out for with these patients that are on diuretics is that they don't have some type of electrolyte imbalance. Using your monitor to take a look to see, do they have elevated potassium or do they have a decrease in potassium? Remember, your 12 leads can give you an indication as to possible potassium levels, you know, based on the waveforms that you're going to see. Now, in our protocols, currently we use it for our pulmonary edema, and we also use it for our hypertensive protocols. We are, Lasix is contraindicated, obviously, in patients with hypersensitivity. One of the big areas that we see so many people using Lasix wrong is that they're not really fully assessing the patients like they should. They're misdiagnosing lung sounds. We see it a lot with patients who are pneumonia patients. We hear the wheezes and we hear crackles. And so people are so quick to want to give the Lasix. And that just causes more complications for those patients. The other thing is a lot of these pulmonary edema patients, they're already dehydrated as it is. Remember, our elderly patients are usually a little bit undernourished. They're not getting the fluids that they normally should. So Lasix, they have been showing, isn't really the best thing for some of these patients. We start off with a 40 milligram is our dose. If they're on Lasix, we can go up to 80 milligrams. And we give it slow IV push. Please do not slam it in these patients, okay? Nice and easy and nice and slow. Watch out for signs and symptoms of hypotension and electrolyte disorders with them. They may actually develop arrhythmias, so having them on a monitor is going to be very important. It can also be used for patients with increased ICP, but again, like I said, there's a lot better medications out there that the hospital is going to use. Anybody have any questions on Lasix? Okay, last medication is nitro. Do you guys do the sprays or the tabs? Okay. Yeah, big talk too about nitro paste. And nitro paste is really nice because it provides a nice, easy, nice, easy dose, but it's messier than Blazes for the most part. The only thing I want to say about the nitro spray, if you do get a nitro spray, make sure you actually spray it in the garbage can once before you give it to the patients. So remember, nitro actually causes coronary artery dilation, reduces preload, and it can reduce that afterload, reduce the systemic vascular resistance on the patients. We don't give it to patients who have hypotension. Remember, are they relatively hypotensive or absolute hypotension? Absolute meaning that they have that blood pressure that's less than 90 systolic. Relative meaning patient's normal blood pressure is 150 over 90, but today they have a blood pressure of 120 over 80. And so that's a little bit less for them. We have to be very cautious. Also make sure that we are very cautious and getting a good history what medications that they may be taking. So we use it for our ACS protocol, those that are experiencing cardiac chest pain, not just chest pain in general. Make sure you're really assessing your patient and making the determination if it's cardiac in nature or musculoskeletal or respiratory. We also use it in our pulmonary edema protocol and then our hypertensive crisis protocol. Contraindications, obviously head trauma, cerebral hemorrhage, that's stroke, or if they use ED medications, such as Viagra within 24 hours, Cialis and Levitra within 48 hours. You guys give it sublingual, goes underneath the tongue. What kind of signs and symptoms, or what kind of side effects should this patient maybe develop?
Headache.
Yeah, headache, lightheadedness. Sometimes it burns underneath the tongue a little bit. If their patients are taking their own nitro at home, we want to ask those questions. Find out when was it opened, when's the expiration date, because it does lose its potency over time. The other thing is, has it been sitting on the counter by the kitchen window, because it is light sensitive. One thing I just want to say about the nitro and the pulmonary edema protocol. I know for a while they were teaching people that once you put that CPAP on, you don't ever take it off. With our pulmonary edema protocol, make sure you're given the nitro first, as long as vital signs are stable, and then every 5 minutes. Remember, it's going to reduce preload, and our CPAP will also reduce preload, so you're going to have to watch your vital signs very closely. But every 5 minutes, working together, it kind of creates that synergistic effect and makes it a lot easier for the patient to actually breathe. So do not feel bad about popping it off, and it's really easy with these new FlowSafe and then with the clips. You can go ahead and give that other nitro right away and put it back on. All right, anybody have any questions about stroke patients? I'm really talking fast today, sorry. Okay, the last section we're going to talk about is our geriatric emergencies. Okay. Yeah, that's the downfall of you guys being last. By next time we are seeing obviously a greater population. From 2011 to currently, we're kind of in, our baby boomers are now in that geriatric stage. Depends on what what reference you're using. Most people say anybody over the age of 65 is considered a senior or a geriatric patient or an elderly person. Our protocols use the age 60. So if you look at our elderly abuse protocol, they talk about being 60 years old. But we are seeing more and more of these patients. They're staying at home longer, but yet they're doing assisted living, independent living. We do have quite a few nursing homes that are popping up all over the place too, where these patients are continuing to live. See here. Must have been on this one. Oh, I might have actually deleted the slide, but we do see a great number of seniors. One of the things that, people over the age of 80 die in fires at a rate 3 times higher than the rest of the population. I'm sure a lot of you guys have already heard about mobile integrated health and how it's affecting EMS and what we're going to be doing to integrate this into how we care for our patients. When we deal with our geriatric patients, even though we don't have specific protocols, but really it's a good idea for you guys to start taking a look at what you can do to help these patients. If they're a constant fall patient, you've been over to Ethel's house 3 times because she slipped and fallen. But maybe suggest to her, let's remove this carpet. You keep tripping on it. Taking a look at things around the house. You guys are the ones that get into these elderly patients' homes. What's unsafe? What's not? Checking the smoke detectors, making sure those are working. Even if you're there for an EMS call and you see the smoke detector, taking a look at it. Are the batteries fresh in it? Is there tripping hazards? Is the oxygen tubing 50 feet running all the way through the house and the patient's only on 2 liters? That we know that's not effective. Suggesting to these patients that maybe they get another oxygen concentrator that they can put in a different room. Their canes or their walkers, they keep pulling up on some of the fabric or different carpeting. Maybe they should put something else or use something else. But we see a lot of our elderly patients and their falls. We see quite a few of these patients in the ER due to some type of trauma, elderly trauma. And falls are the most common ones. The problem with our elderly patients is even a simple fall from a standing position, they can end up having cervical spinal injuries, fractures of the cervical spine. So we need to take great caution with them, even though they may not necessarily have that pain sensation, because remember, these patients, they have that decreased pain sensation. They're not going to complain about things like they may have done 20 or 30 years ago. So our assessment is going to need to be spot on with this. Putting a C-collar and stabilizing the neck right off the bat if they've taken a fall is very important. Now remember our spinal immobilization protocol. We can still go ahead and put these patients directly on our cots because our cots are considered a padded backboard. And they can sit up or be at that semi-Fowler's position if that's more comfortable for them. We see our elderly patients break hips or have dislocated hips, broken femurs. So we want to go ahead and treat them with the utmost care. Using a scoop stretcher to get them up off the floor and put them on the cot and then removing it is going to be very important. Making sure we're checking the distal pulses on these patients to make sure they still have circulation. But we do see a lot of injuries. Also, car accidents. How many of these elderly patients probably shouldn't be driving? Their reaction time is greatly diminished. They're not as, they're undernourished or they suffer from bits of dehydration. Heart disease is also another common emergency in our elderly patients. We see quite a few of these patients, not just with past heart attacks, but with left ventricular hypertrophy. You take any muscle within the body and the more you work it, the bigger it gets. You go ahead and you lift muscles, or lift weights to try and build your muscles. Well, the heart also, it's been used so much and it continues on. And we see the systemic resistance in our vascular system, so the heart has to work harder to push blood throughout the body. So these patients will develop an enlarged left ventricle. Also, that left ventricle has a tendency to dilate. So we'll see a decrease in cardiac output, a decrease in the volume of blood that actually gets pushed out to the rest of the body. Heart failure patients is also, besides left ventricular hypertrophy, the heart failure, heart attacks, just trying to think what other types, coronary artery disease. You got patients with high cholesterol. So some of the things that we will see with these patients that when they have chest pain, sure, we go through all the cardiac, but don't forget, patients can have chest pain for other reasons. It could be musculoskeletal in nature. It could go ahead and be something respiratory. So we need to do that great assessment. Even the emotional, the anxiety, the kids don't come visit anymore. They're anxious about the fact that they're on a secured income or an income that they don't have enough money to pay their bills or get their medications. And that's the other thing. A lot of these medications are coming so expensive that these patients, they'll take only half of their tablet or they can't afford their medication at all, so they won't take them at all. So we see a various amount of different things going on with them. With the medications also, they're on so many different types. And it's not like they go to one doctor. They've got, their heart doctor at one hospital, they've got their GI doctor at another hospital, their primary care doctor at another hospital. Hopefully they're using the same pharmacist, because the pharmacist then can take a look at all their medications and see if there's any interactions to any of those medications, and try and keep everything in check. Because a lot of times the doctors may not always catch or pay attention to what other doctors are prescribing. Some of these patients too will forget to take their medications. They lose track of the day, they lose track of the time. So they'll go ahead and take it, and then they realize, oh, I haven't taken it in a couple days. Or, did I take my medications this morning? I don't remember, so they'll take more. So they can self-medicate or overdose themselves. Abdominal pain also is another big concern for our geriatric patients. A lot of different GI problems. We see them with food poisoning. Food sits in the cupboard for a long period of time, or the refrigerator. They go ahead and they eat it because they think it's safe, and they end up with food poisoning. They don't have the money to replace the food, so they're very frugal and try and keep their spending down a little bit. Sometimes they don't eat like they should, so they're undernourished. They don't drink fluids like they should, so they can become dehydrated. Respiratory concerns. One of the big things to remember is old geezers don't become new wheezers.
Old geezer.
Old geezers, yeah. So you have a patient you get called out for at 7 o'clock in the morning, and this patient is sitting at their end of their bed, dangling their feet, kind of in that tripod position. As you walk in the room, you can hear them gurgling and wheezing across the room. Sometimes we get that tunnel vision, we think, oh, they're wheezing. Albuterol will fix it. Remember, albuterol bronchodilates, decreases the inflammation in the bronchioles. But with this patient, if they had no respiratory history, they're not all of a sudden going to develop that asthma overnight. Take a look at their history. Do they have a cardiac history? What medications are they on? This patient may very well be suffering from what we can kind of consider cardiac asthma. They're wheezing because the bronchioles are being smashed down instead of being constricted. And the albuterol isn't going to go ahead and be effective with these patients. And it actually can do more damage to the patient. Think about what the heart, you've got this heart that's not pumping effectively. They've got pulmonary edema building up. And so they're trying very, very hard. The heart's pumping against the systemic vascular resistance. Now you give a medication such as albuterol, you're going to make the heart work harder. You're going to increase oxygen demand. And so that can actually cause more damage to the heart than if we had treated them right. So make sure you're taking a look at everything with these patients and realize that they're not going to develop asthma overnight. We see a lot of them with the pulmonary diseases, the COPDs, the chronic bronchitis, the emphysema. A lot of them, when they're coughing, ask them, is it a productive cough? Are you coughing anything up? What color is the empyema that they're coughing up? Try and get something to figure out, is it pneumonia? Is it emphysema? Is it bronchitis? Remember also with our heart failure patients, what they cough up is more of a pink frothy sputum than some thick mucus at some point. Pneumonia is also very common in our elderly patients. This is a good idea too, with your history. Have you been feeling sick for the last couple days? Do you have a fever? But remember, not all pneumonia patients do experience a fever. Are they having any shortness of breath? What's their pulse oximetry? But remember, the pulse oximetry, we can have a lot of negative results on this. It may not be accurate. Your best bet is to go ahead and use your end-tidal CO2 on your breathing patients, or any of these patients that are having shortness of breath. Urinary tract infections is one of the #1 reasons that elderly patients have altered mental status. Yeah, everybody knows you walk into a room, you can smell when someone has a UTI. These patients are very susceptible to sepsis or systemic inflammatory response, ultimately developing the multiple organ dysfunction syndrome. So the best way for these guys to cure this is to drink plenty of fluids. And again, remember, our elderly patients, a lot of them don't get enough fluids. 31% are chronically dehydrated. Making sure that you're checking body temperatures if someone has a UTI. Starting an IV on them, giving them fluids. Checking their vital signs. Are we starting to see a decrease in blood pressures? Ultimately, if it gets so bad it ends up being septic, these patients can die from something. We've already gone ahead and gone over the stroke being the 5th leading cause of death in the United States. Again, does anybody have any questions on the stroke? We talked earlier in the beginning, we talked about the injuries and how to go ahead and stabilize these patients and how brittle their bones are. All the different types, kyphosis, osteoporosis, brittle bone disease for these elderly patients. Now they've taken that fall and they've possibly injured their neck or their spine. In the past, our protocols has always said, put a seat collar on, put them on a backboard. But these elderly patients can't tolerate a backboard. That hard backboard is very uncomfortable. They're going to squirm and move around more, which is going to be more detrimental to the patient. Their skin is so thin that even after 17 minutes, they can start to develop tissue breakdown, which can ultimately lead to decubitus ulcers and other infections at that point in time. The best thing to do with these patients, again, like I said, if you do need to spinal immobilize them, use your backboard to move them up to your cot, and then you can move them to your cot. Get them off that backboard as soon as possible. Some of them too, with the way their bodies are hunched over, make sure you're patting the voids, making sure they're as comfortable. Use tape to go ahead and secure their head down straight to your cot if necessary. Now, some of these elderly patients too, they also fail to thrive. They're alone in this world, their family lives a distance away, or their families are very busy. They don't have time to go ahead and come over and take care of them. We see a lot of these elderly patients, they're not eating like they should, so they have that decrease in appetite. So they're poor nutrition, they're undernourished. They start to sit in their chair all day and just watch TV. They don't get out, they don't see people. And this is all this big chain of events because at this point, they start to become depressed. They're not seeing people and visiting with them. And once they become depressed, it just leads them down a whole nother avenue. They can turn to drug and alcohol abuse. They start to get depressed. Dementia maybe sets in. They start worrying about their bills. Do they have enough money? And ultimately, they just go ahead and they give up on life altogether. So some of the things to take a look at with some of our elderly patients. Now, one thing, and I don't know how many of you guys realize. You guys are invited into these patients' home when they call 911. You are seeing how they live. Are they hoarders? Is their house clean? Is there rotting food on the counters? Is there cat pieces all over? All of the ERs, both at Evanston and St. Francis, we have a case manager. Now, a lot of times people think, well, it's the doctor that discharges them back home. Yes, that is true, but these case managers ultimately work with the doctors to say, are they able to go home? if you guys truly believe that a patient should not be going back to their home, this is the 5th time this week you've picked them up off the floor because they've tripped on all of their belongings in their house, or they're not eating appropriately, their sugars are always done. You can ask for the case manager in the ER and explain to them what you're seeing, or tell the doctor what you're seeing in that ER or in that house, and that can help them make the determination. Maybe they should be in a nursing home, or maybe they should be in an assisted living home instead of at home by themselves. But again, this kind of goes back to this whole global type of patient care, not just taking care of them right here, right now with the problem, but hopefully preventing future calls from them, future falls, future problems for them. Kind of a full service plan there. Some of the other things we see with our elderly, they have difficulty hearing. And some of them will actually end up with Meniere's disease or vertigo, the equilibrium problems due to hearing problems. Just remember, not all elderly patients are difficult or have a hard time breathing. And we see people walk in and they raise their voice 10 octaves. And it is kind of rude to start screaming at some of these elderly patients. So, kind of assess them before you go ahead. Vision loss is also another issue. We see cataracts and glaucoma as being the common eye problems for these elderly patients. And that can also relate to other issues. They can't see very well, they're tripping, they're falling, they're dropping things, they see things with the stove, they try and put a hot pan on the stove and they miss it and it goes all over the ground. So as I was saying before with the backboards, these elderly patients, their skin gets to be really thin. Do you guys keep paper tape on your ambulances? Or do you just use regular plastic transport? Yeah, these elderly patients, try using the paper tape. I know it doesn't stick very well, but that transport tape or the plastic tape can literally tear some of these patients' skin, kind of right off. We see skin tears on these patients. Ultimately, they can break down and end up with the cubitus ulcers. When you guys are assessing your patients, it's always a good idea to document anything that is abnormal. Not maybe abnormal for them, but it's not normal for elderly patients to have bruises and skin tears all over their arms. So when you're writing up your assessment, say patient had multiple skin tears on their left forearm, multiple bruises on their right arm, and document anything that is out of the ordinary for these patients. Sometimes even grabbing a hold of a patient's arms or shoulders to lift them up, you can cause little avulsions and skin tears on them. So just treat them with caution. Any questions on any of the conditions? All right, we're going to kind of go into DNR and hospice. Now, about 2 weeks ago, Adam sent out to all the medical officers a copy of the PULSE form. This actually changed, I think it was back in 2013 or 2014. It's the new state DNR. And it's been around for, like I said, a couple years, but we really haven't done a whole lot. I know in September before I came, they did an in-service. But the PULSE form is replacing the old DNR forms. The whole idea with this PULSE form is that every state in the United States uses one so that it's consistent. Now, let me just pull one up for you so you can take a look at it. They can be kind of confusing at times because it's kind of an a la carte, gives you a little bit of direction. So, first of all, the PULSE form, it doesn't have to be the original. You can have a copy. It doesn't have to be on that pink salmon paper that it used to have to be on. All right? This goes into effect whether a patient still has a pulse or not. The old DNR form only took effect when the patient was pulseless and non-breathing. A DNR form does not mean do not treat. So there's a couple things that actually has to be on this form to be valid. the patient has to sign it, there had to be a witness, and the physician has to have their name printed, signed, and date. Now, if the patient is unable to sign on their own, their POA or their surrogate can go ahead and sign for them. So box A, box A, pretty self-explanatory. My patient does not have a pulse. Either yes, I do CPR, or no, I don't do CPR. Pretty straightforward. You don't have to go any further at this point in time. Where it gets to be a little bit confusing for people is when we get to box B. Because in the past, you've been told we do not honor living wills, and that is still true. You can go to the hospital, talk to the chaplain at the hospital, and ask for a packet of a living will. You can take it home, go ahead and have it signed or fill it out, take it into and be notarized, give it to your hospital, the doctor, and everybody, and the hospital will honor that. But you guys are not allowed to honor that. This here, since you're not used to it, can be rather confusing. And I'll be honest, as you're sitting there trying to decipher this, you can still be confused. It's not as straightforward as what it should be. And like I said, you're spending time doing this when you could actually be caring for the patient. Bottom line, if you're confused, call medical control and ask them. But box A says full treatment. Primary goal is sustaining life by medically indicated means. In addition to treatment described in the selective treatment and focused treatments, you can use intubation, mechanical ventilation, cardioversion as indicated, and transfer them to the hospital, and they don't care if a patient is in the ICU. Now, what can get confusing is you may have box A say, do not attempt resuscitation, but box B says, why I'm still alive, I want everything done for me. So it gets to be a little overwhelming, confusing. I wish they would have done something a little bit better with it. But now, the second one, selected treatment. Primary goal of treating medical conditions with selected medical measures. So this person used medical treatments such as IV fluids, IV medications, antibiotics, vasopressors. You do not intubate this patient, but you can use CPAP or BiPAP. You can take them to the hospital, but they don't want to go into an ICU. So again, do I start an IV on this patient? Yeah, you can start an IV. Do I give medications? Yeah, you can. Do I want to shock them or pace them if their heart rate's really low? No. So again, I apologize for this. There's not a whole lot we can do. Finally, the last one says comfort-focused treatments. This is if a patient is suffering in pain, you can use medications to relieve the pain. You can give them oxygen, suction, manual treatment of airway obstruction. Do not do not use treatments listed in full or selected treatments. So don't intubate them, don't cardiovert them, don't pace them, don't use vasopressors, antibiotics, things like that. This is just to make them comfortable. And request transfer to hospital only if comfort needs cannot be managed at home. See why I mean this is really kind of confusing for you guys, and sometimes the best thing to do is just call medical control and ask them what they think is best.